let's talk about anemia of chronic disease. Anemia of chronic disease is arguably the most nuanced anemia to understand because its mechanisms are diverse and overlapping rather than a single clean pathway. It arises from a constellation of processes that all occur downstream of chronic inflammation. Altered iron metabolism, suppressed erythropoiesis, meaning the bone marrow is being actively inhibited from producing red cells, and a mild shortening of red cell survival. All of these are orchestrated by inflammatory cytokines and by a hormone called hepcidin, which is upregulated in inflammation and acts as the master regulator of iron availability. The red cells in this condition are most often normochromic and normocytic, normal in both color and size. But here is the important nuance. They can also appear hypochromic and microcytic, perfectly mimicking iron deficiency anemia on the blood smear. And to add another layer of complexity, they can occasionally present as macrocytic as well. This morphological variability across all three size categories is part of what makes anemia of chronic disease diagnostically tricky and easy to misclassify. The single most important laboratory tool for separating anemia of chronic disease from iron deficiency anemia is the total iron binding capacity, and this is where the delivery truck analogy becomes critical again. In anemia of chronic disease, serum iron is low, just as it is in iron deficiency. But unlike iron deficiency, the total iron binding capacity is also low or normal, not elevated. Why? Because the inflammatory environment actively suppresses the production of transferrin, those iron delivery trucks. So in anemia of chronic disease, you have fewer trucks on the road, and they are mostly empty. In iron deficiency, you have more trucks than ever, also empty. Both conditions show low iron, but the direction of iron binding capacity flips, and that flip is the key diagnostic discriminator that allows a clinician to tell the two conditions apart without resorting to bone marrow biopsy in most cases. The chronic conditions most commonly responsible for this type of anemia include rheumatoid arthritis, chronic kidney disease, and persistent infections. In each of these, the sustained inflammatory state drives the pathological iron sequestration and marrow suppression that define the syndrome. In summary, anemia of chronic disease typically presents as a normocytic, normochromic anemia with low serum iron, low total iron binding capacity, TIBC, and normal or increased ferritin levels. This distinguishes it from iron deficiency anemia, which features low ferritin and elevated TIBC. Pathophysiology. It's mediated by increased hepcidin production from chronic inflammation, reducing iron absorption and promoting iron sequestration in macrophages, leading to functional iron deficiency and impaired erythropoiesis.